sides. So the objective of this webinar is that we want to introduce the precision medicine reference case to the healthcare community, present the structure and domains of the PICCOTEAM precision medicine reference case, and demonstrate the application of precision medicine reference case through real-world case studies. We have structured this webinar into 3 parts. First, we will be walking you through the development of how we develop the reference case for precision medicine. Second, we will be going deep into the 9 domains of the reference case that we have developed. And lastly, we would be sharing with you an example from real-world case study wherein we used this reference case for its application. So before we begin, what is precision medicine? Precision medicine is a medical approach that separates people into particular groups for optimizing the efficiency or therapeutic benefit of the population. The precision medicine is defined as something that takes individual variation in genetics, environmental, and lifestyle factors into account, allowing doctors to more accurately predict which treatment and prevention strategies will work in different group of people. Applications of PM are broadly categorized in 2 types. The first one is test-guided PM, where we have screening test, diagnostic test, and prognostic test. Screening test is basically used to screen the undiagnosed population for diagnosis. Using precision medicine, we can make early diagnosis of disease. Examples include pediatric genetic diseases, rare diseases, and some other undiagnosed cancers. Lastly, prognostic test is used to prognose for how the disease would respond. For the second category of precision medicine wherein it's applied is therapeutic precision medicine, wherein we can predict adverse drug reaction, treatment efficacy, and/or drug dosage to stratify patients by optimizing their treatment. Now, the rationale for this study includes several reasons. So firstly, we know that precision medicine is fast-growing medical approach with rapid advancement leading to complexity in its scope and application. Recently, number of precision medicine tools have started using omic-based biomarkers, including proteomics, metabolomics, and lipidomics, that estimates disease prognosis and predict the treatment response. A single omic-based technology can inform treatment pathways, therapy choices, or disease risk all at once. Second reason is that the number of diagnostic tests since 2012 to present have multiplied. So in 2012, we had 1,000 tests available for just 900 genes, whereas now we have more than 50,000 tests available for over 16,000 genes. However, the adoption and uptake rate still remains low for these increasing number of technologies that are coming to the market. And also one might note that introducing a new precision medicine into healthcare system requires large collective resources to fund, and hence it becomes very essential to determine the value for money that we are spending for precision medicine technology. Now, health technology is an assessment is a process that uses explicit methods for determining the value of health technology at different points in life cycle. We know that precision medicine intervention has the potential to reduce the burden of disease, reduce the cost and potential adverse events. The inclusion of it into healthcare comes at a very high bearing cost. Thus, the benefit of precision medicine should be captured in health economic framework that justifies the allocation of resources for investment in both research and development stage, which we call here early HTA, as well as for the reimbursement stage, wherein we can conduct a traditional HTA. But there are certain challenges in conducting economic evaluation of precision medicine, and determining the value for money depends on variety of factors. And with precision medicine, the challenges can be very specific. For example, starting from defining the population, where we have an evolving patient population, and there are subcategories of population divided based on genetic groups. We also have a population which expands because of newer technology, and then there is a heterogeneity of patients. Second, on intervention side, the scope of intervention, which is precision medicine technology, is uncertain. The clinical decision space is complex, using consistency of sequential testing, variations in result interpretations, and rapidly evolving clinical pathways. And hence we have this leaves us with complex decision space. And there is also lack of evidence for test validity and reproducibility. In the literature also, for the economic evaluations that were conducted for precision medicine, we have found that not many researchers report on test validity and reproducibility. Lastly, for the intervention, there's also for the comparator, often the justifications and the reporting of the comparator is limited, and the comparator that is used is almost standard of care or no treatment at all. And this becomes difficult to define when we are modeling. For outcomes in literature of cost effectiveness studies, there were several limitations noted, including lack of long-term data and real-world evidence, disease and patient-specific outcomes that were underreported, limited effect evidence because of randomized control trials that were not extended beyond certain time. Not all potential values of the precision medicines were reflected. And there was also been inconsistency in reporting disease-specific outcomes. Often the intergenerational effect of a precision medicine is not captured when conducting economic evaluation. And when we are looking at the costs, the value of precision medicine technology with unit cost is not measured, and we often overlook test treatment pathways and the costs that are associated with it. When it comes to modeling, although the list can go on and on, but some of the challenges that we have found are related to model complexity, wherein the test accuracy and uptake and compliances were overlooked. It is also difficult to capture all the relevant patient outcomes, and sometimes the societal and non-health effects are not measured. Lastly, there are challenges related to equity and ethics, as well as limited adaptability of findings. So, like clinical guideline, HTA is applied research on health technologies, and studies have to be credible and directly answer policy relevant questions, and it should be doable within time and budget, and there should be consistent and fair across technologies within a class. So like any clinical guideline, reference cases both lead and follow practice. Knowing patient technology is essential to knowing how to process. And what is a reference case? A reference case for economic evaluation aims to standardize methods for appraisal of clinical and cost effectiveness of new technology, focusing on single intervention across single population. But in the study that we conducted, we found that generic reference cases often fail to address the precision medicine specific challenge, which I highlighted earlier, some of which I'll say include spillover effects, expanding target population, complex test treatment pathways, intergenerational impact, ethical issues, and also issues around early economic evaluations were not mentioned in generic reference cases. In another study that we conducted, we also found that there was a high risk of systematic bias for the existing economic evaluations for precision medicine. And there is also a potential room for study manipulation. And cost effectiveness evidence was often concentrated from established application as well as in established in developed countries. A precision specific, that's why we found that there was a need for a precision medicine specific reference case to ensure consistency, transparency, and comparability in conduct and report. Now, I'll quickly walk you through the steps which I have articulated earlier. So the development of this reference case comes through a very deliberative steps. First, what we did was we conducted a cost effectiveness analysis, systematic literature review of cost effectiveness analysis of precision medicine technologies. Research teams from HITAP and NUS jointly performed this review. And the studies that were reviewed were from 2011 to 2021. 275 relevant papers were found, and we explored the drivers of heterogeneity in precision medicine. Following that, we also conducted a narrative review of methodological challenges with precision medicine economic evaluation. And thus, we were able to map all these challenges into development of an initial draft of precision medicine reference case. So first, there was a consensus that was obtained through expert consultation. Then once we got a consensus on our initial draft of the precision medicine reference case, we also held a stakeholder consultative workshop that was 3-day workshop, wherein representatives from Singapore, Precise, as well as from Thailand, clinicians and health economic experts who is specializing in precision medicine, jointly came and revised the reference case based on its relevance and applicability and feasibility. Finally, we come to the reference case, which we will be walking in depth now. So this reference case is a 9 uh, domain framework known as PICCOTEAM reference case. We have 40 recommendations for conventional economic evaluation and 31 recommendations for early economic evaluation. The reference case has been developed over the years, and I hope that you would be able to learn about its application and more. So now I'll pass over the mic to Professor Finsha Chan.
Thank you very much, Dimple, for the introduction of the making of this PMRC. And for the next 40 minutes or so, I'm gonna walk you through the detailed component of this PMRC using a case study as an example. So you can scan this QR code and find the website that we have put our PICCOTEAM reference case into a web app that allows you to check each item and also to enter responses there. So this checklist is used as a supplement of generic reference case for conducting economic evaluation, but it provides specific guidance on the evaluating the precision medicine. So if you have already scanned this QR code and go to come to this web page, you will be able to first make sure that what type of health economic evaluation are you planning to conduct. So there are two types of economic evaluation or HTA. The conventional HTA assess the health technology, the PM, that is ready to enter into the market. So it's at market access stage. And the purpose of conducting conventional EE is to inform the exact cost effectiveness profile and the clinical pathways to help the policymakers to make decisions about regulation and reimbursement of this technology and how this technology is going to be used, put into clinical guidelines. But for early HTA, the purpose will be entirely different, and the recommendation will be more to support you to conduct a study that is exploratory, that it will help to evaluate PM technology from the very early stage until close to market access. And depending on different the need of different stages, it can be used to prioritize the product and also the clinical pathway to be developed, and also the design the target product profile such as cost and performance package, and to make it competitive to the best alternatives in the market. And later, the early HTA can support the design of clinical studies and real world studies to collect key evidence and to capture all the potential benefit. So depending on what you plan to do, you can choose either the recommendation for a conventional economic evaluation or early economic evaluation. And then after you make the decision, you will come to the next page that there are 4 types of genetic tests. So this reference case is focused on providing guidance to assess genetic tests. We haven't come up with a concrete solution for gene therapy yet. And although one genetic test can have multiple purpose, but you can select the one that you think you will be interested to evaluate. For example, that why whole exome sequencing can be used for diagnostic of early detection of a disease, or the genetic subtype of a already diagnosed disease. So it has 2 type of applications, and you can choose the one that you're interested. So no matter which one you choose, the recommendations will be made to all, and with specifications made on certain type of genetic tests as a side note. So before we go into the reference case, I would like to use the pilot study, the Thai FH care study, as an example to enter my responses to the recommendations. And for this project, it's actually the cost effectiveness analysis of a cascade testing of familial hypercholesterolemia, a genetic mutation in Thailand. So the FH, the genetic FH will be greatly elevate the risk of cardiovascular conditions and death. It will be great to identify these patients with genetic FH early in life, so as to prevent the later consequences. Okay, so let's go to the website. Can I? Oh, it's already there, right? Yeah. Okay, so as you can see in the screen, I can read and accept these privacy policy. And today, first, I would like to show you an example of using this guideline to guide the study of the FH care on using whole exome sequencing and MLPA, a supplementary genetic test, to identify the relatives of a index patient who has genetic FH, to identify his or her relatives who's also having genetic FH and give them early treatment. So I'll click this, and then for my for our FH care project, it's actually having overlapping indications. For patients with high lipid level, we will be conducting a test to identify the subtype that has genetic mutation, and then we will identify early the relatives who has the genetic mutation too. So my primary interest is the cascade testing. I will enter early diagnosis. And you can see there are 9 domains. The recommendation will given in 9 domains of this study, and these 9 domains help you shape the clinical pathway and the economic model, and also to conduct the economic model and assess additional concerns in equity, ethics, and the interpretability, transferability of the results. Okay, so the first domain is population. And it's most important to define the target. I see. I can see. I have to click.
Yeah, I can minimize.
Can you help me move that TV to me? Dr. Yo, can you run this?
No, but you need to change.
Yes.
Doctor, it's okay. Can I?
Yeah. As long as I can move the mouse.
Yeah, you can move now. You can move now.
I can see it. Can I have the website?
Can you look at from that one? From that, if you want to share.
But like she needs to move the
Mouse. Yes, I need to move the mouse. I can see the mouse.
I can help you move. I can help you. Okay. Yeah, yes. Okay.
Yeah.
I can help you move.
I need to type where to type.
Coming.
Okay, great. It's coming back. Okay, so for the population domain, it's of utmost importance to define the target population in terms of whether you want to evaluate a stratified population with certain already known genetic information, or you want to just target the entire population. And it has something to do with the scope of the target, the genetic test that you want to evaluate. For example, for screening tests of a disease disposition, then you may want to consider the entire population suitable for screening. For example, for screening breast cancer early using genetic tests. And for diagnostic tests, maybe you want to focus on the probants who has the mutation and then screen their relatives. And for pharmacogenomic tests that you would like to identify their treatment effectiveness, then you consider the relevant patient group for the treatment. So in our case, we know that our target population is FH genetic, it's patients with high LDL level and mutation, genetic FH diagnosed, and their relatives, right? Yes. So you can enter these into every commentary box, and then we already identify the target population to be the probants and the relatives of the diagnostic test. And then for there are some recommendation you may or may not be relevant to your study, such as update and expand the target population as the test evolves. Here in our study, we do find a better test, but it's we do not update or expand the target population, but rather we compare to a greater to another test. Yeah, which is the long read sequencing as one of our options of intervention. Yeah, then you can click next, and then when it goes to intervention, the intervention to design a intervention pathway, our reference case strongly recommend the engagement of experts, the clinical experts, in designing the interventional pathway. And before you design the interventional pathway, of course, you need to decide what this test is mainly about. As we said, that our whole exome sequencing test will be detecting genetic subtype and then screen their relatives for early diagnosis. So cascade testing, yes, we say it's our main focus is on this one. Although it has multiple implications, but you can enter different implications that you want to evaluate. So let me see, I would like to copy paste, right? Just as my comments, and then because later you're gonna have a study report, a report on the checklist that the recommendations that you have been used and your comments. And when defining the interventional pathways, it will be very important to involve clinical experts and to understand at the initial step the complexity of clinical pathways. And it should be involve at least 5 domains: test delivery, test result. Like test delivery for our case is that we will be conducting tests and then receive the result and then test the relatives. So which is part of the delivery test delivery process, and the diagnostic decision, what is that decision, and the treatment decision for those who has a diagnosis. In our case, we'll give them statin if they have genetic FH to prevent the future cardiovascular conditions onset. And then the treatment implementation following that. So there is a decision space involved into this process. So for each step, there will be like a decision node, whether you conducted this or not, and the compliance rate. And you can also integrate timing, feasibility, accuracy of the test, the uncertainty in the decision, efficacy of treatment and adherence into the pathways. So we can say here we have cascade testing plus statin. Cascade testing plus lipid confirmatory test. So you can design your treatment plan, and then at the initial step, it's the step that explore the complexity, and then in the following step, it will be a major step to simplify the process and design the major intervention strategies and their relevance and feasibility in your current local setting. For example, for the FH care study, we adopted this model structure from the Singapore FH care structure. FH care study, but the Singapore study has involved 2 confirmatory tests after the whole exome sequencing, WES. But in Thailand, we decided that we just use 1 confirmatory test for the test negatives. So and it's also important to involve clinical experts into the process. And then after you design the interventional pathways using this reference case, you can identify the comparators. For conventional HTA, we should always consider the current standard of care as a common comparator. So for our study, it will be just a random lipid test. And that's it. We don't do anything else in the comparator arm. And yes, there will be a necessity to justify the choice of comparators because this is what has been used in the Thailand setting. And expert elicitation, when you have like a extra efforts, it will be recommended to conduct extra expert interview to assess all other potential comparators based on the feasibility. For example, in our study, we consulted with a leading oncologist PM researcher, Dr. Barasak, and we additionally included a newer technology called long-read sequencing as a potential comparison. So, yes. And then once you identify the intervention and comparator following the definition of target population, it will be a process that you collect cost and outcome data for both the intervention arm, you identify the intervention protocol already, and the comparator arm. And for costs and outcomes, for both these 2 endpoints, we will be recommending you to measure them from a societal perspective, which means that you collect the evidence not only related to the healthcare resource utilization or the time or traffic that or the days off that you because of receiving healthcare, but also from a broader societal perspective to identify the impact or measure the costs and the outcomes that is on the productivity, the work productivity, labor force, and even the intergenerational effects on the next generation. So in the FH care study, we did measure costs from a societal perspective, and Yue will be telling you more about that. And also, for direct medical costs, we will be considering the full cost of the test, even if it's subsidized by the manufacturer. And we will be considered all relevant direct medical costs. And we provided a detailed list that you can take time to read and see if for any cost you cannot be you cannot measure from your own end. Maybe you can just specify that we did not include data storage cost, so that you will keep these on track, and then it will be helpful for you to write a study report later. Because the reference case is conducted not only to guide you to conduct the study, but also to report the findings. And we did adopt expert opinion, which is very important because the clinical experts will be, and the manufacturer will have a better idea about what are the costs that you should be including. And we may want to distinguish the cost that impact cost effective from budget impact. For example, the budget impact can have like a test cost, treatment cost, but the cost effectiveness, we also measure the cost because of healthcare use. Like if you have improved health, then you will maybe reduce the healthcare costs. Yeah, and for some of the studies, if you want to do the patient level simulation modeling, you may want to consider the impact of potential variation of costs, unit cost of PM. But sometimes it's simply not feasible. and or it takes time for you to collect the evidence, or it's brand new and you can only discuss about the likely scenarios once it's being implemented, then you can at least discuss about it. So in our case, we would be discussing economies of scope. Economics. Economies of scope means that once the test has been put to use, such as WES, it's actually aiming for multiple diseases that can be treatable at the same time. So it doesn't, the cost effectiveness that is focused on screening FH may not fully reflect or may even underestimate its cost effectiveness by aiming at multiple conditions at the same time. And the economies of scale means that once the test is put to use, more and more people are using it, then the cost will be gradually reduced over time. Okay, so the take-home message here, and sometimes the cost can differentiate between test positive and negative results. In our case, if the patient receive a negative test from WES, then this patient needs to conduct another confirmatory MLPA test to confirm whether it's not mutated or not. So yes, we consider like a negative additional test. Yes, and maybe there are also a time difference as well, although we did not capture, no capturing of no capture of cost of turnaround time limitation, right? If you can't, then it's a limitation that you can put. So the take-home message from the cost domain is that we need to consider the full cost of the test, and we need to consider all the direct medical costs by referring to this checklist and involving experts to see what are the costs that may be potentially missing that is unique to the local setting. And also, we need to try our best to measure costs from the societal perspective. And similarly for the outcome, from a societal perspective, you may be able to capture some outcomes that are related to like the labor force, and you need to follow the common guidelines and reference disease models to identify these outcomes is possible. In our case, we use a established model. So when you are conducting a genetic test on a new condition, try to find a reference model or like a guideline to conduct these kind of like a disease and find the disease specific health outcomes. And for evidence selection, we be recommending similar as other like economic evaluations that you should follow the hierarchy of evidence to get the best will be meta-analysis or randomized control trials or single-arm trials, and then real-world data. But different from other like a generic reference case, we make more recommendations about how to extrapolate real-world evidence because in fact, for precision medicine, the clinical evidence on the effectiveness of the test itself will be scarce. The aim of precision medicine is to stratify patients into subgroups, and it's very difficult to obtain the comparative effectiveness from a designed trial from these subgroups. So sometimes you need to extrapolate real-world evidence. And our recommendation is that you select the observational studies, preferably those who already apply statistical methods, like to adjust for selection bias and confounding, such as propensity score matched, propensity score weighted studies that compare the outcomes, and also like at least apply regression analysis and adjust it for confounding effects. But sometimes for our study, actually, it's not applicable, or you can click no because we have very limited local evidence. So we can only have summary stats and expert opinions. Okay, so once you identify the outcome, you need to also specify whether it's disease specific or general. For us, we use disease specific outcome because we follow an established model to identify the preventable case of cardiovascular diseases, and then the relevant outcomes like death, and they are like the healthcare for the cardiovascular conditions, and the impact. Whether you have included the impact of labor force, like a work productivity or social level value, will be also something that you may need to pay attention to, although this is less relevant to pharmacogenomic tests because it's like a ranking treatment effect, and to select better treatment. So for our case, yes, but it's reflected in indirect cost due to productivity loss change. Yeah. Okay. And likely that for other type of genetic tests other than cascade testing, maybe it will have an impact on family members, although we don't have it now. And it's less relevant to population level screening tests. And sometimes surrogate outcome will be used, then we have provide specific recommendation here, but it's not relevant to our study. And you can take time to read when you have time and you have to use surrogate outcome. But the take-home message from the outcome domain is that first, we will need to follow established guideline or disease, the most typical disease model to collect the outcome that better to be specific to the disease rather than specific to the treatment. And then follow a societal perspective and try to capture the impact on labor force, even if it's reflected in the productivity loss and in the indirect costs. And for selecting or extrapolating real-world evidence, it will be recommended to identify the high-quality observational studies that already conducted the causal inference, analysis, because many of these studies may be biased if by the confounding factors if it's only from descriptive analysis. Okay, so next, the time horizon of a genetic test once it's reaching to the market access stage will be strongly recommended to use an extended time horizon to capture the lifetime effect of these genetic tests, because one genetic test can already inform the predisposition of a genetic information and likely disease over a long time. And even when feasible, we should be harness the intergenerational advantages of genetic tests. Yes. So here we use a lifetime horizon. You can specify what you want to do. We use a lifetime horizon and discount the future and outcome cost and outcome using the most recent national guidelines as inconsistent with other generic reference case. Sometimes if you want to estimate the intergenerational effect for such as the rare disease screening for prenatal mothers, right? Then you can apply specific discount rate, but we did not do it here because we are studying the relatives and the newborn. We are studying in our FH care study, the screening age is older, so we don't consider the intergenerational effects. Sorry. And on. Yes. Okay. So an important part of this study report, at least you should put into the study report that you ensure the principles of non-discrimination and equality of opportunity are applied when you are designing the model and making relevant policy recommendations. And it should be in the discussion. And when feasible, there are specific quantitative methods that you can incorporate health inequality into the economic evaluation, such as the distributional cost effectiveness analysis. If you have time, you can read more about that. but sometimes it's quite difficult and maybe very time consuming to conduct this type of tests. So we will be recommending it to whenever it's applicable and very much needed. Okay, and we did not do it here, so we put it into the discussion. And also, when we conduct a economic evaluation on precision medicine, because we are already focusing on the genetic subtype, we need to make sure that the result can be transferable, at least in this country, and better it can be transferable to other similar countries with similar characteristics. So to ensure the generalizability, it's recommended to apply generic model and nationally representative data and use multiple scenario analysis to enhance the applicability of the results. And we did that in our study already. Okay, the final domain is the modeling. After you have identified the target population, designed interventional and comparator pathways, collected relevant costs, decided how to collect the relevant costs. When it comes to modeling issues, yes, in alignment with the previous recommendation, we'll be recommending to use a societal perspective whenever applicable. And the key take-home message here is, of course, you need to adhere to established guidelines when designing the economic model. And better if you have a reference model, you can use it and make your own a modification on that. And well, for the modeling issues, we already mentioned that we will increase the use of expert opinions in determining the structure, which should be already determined once you have identified the interventional and comparator pathways. But one thing very important for precision medicine is that it's associated with a lot of decision uncertainty. So precision medicine is a test to support clinical decision and on the treatment and the diagnosis and screening for other populations. So an important recommendation from the modeling part is that make sure to incorporate test accuracy in terms of false negative to false positives into the clinical pathway in the models, and also the effects and this utility from harm from testing if possible, as well as some decision uncertainty following the test results, which should be integrated when you are trying to design the interventional pathway. Although we would like to remind you that for pharmacogenomic tests, because it's a very complicated issue, in order to simplify the pathways, maybe it would not be very highly relevant to complicate the model by the test accuracy and many of these items. Yeah. And model. So the take-home message for the modeling part: first, follow the established guideline to best practice guideline and reference model to build the model itself, and integrate the interventional and comparator pathways and the decision nodes that can be used to parameterize decision uncertainty, or say structural uncertainty in the clinical decision space. And many of the recommendations are already reflected in the previous domains. For example, for data extrapolation, you follow the best practice guideline to select the best quality observational studies. But if you can't, then when you are using the data to extrapolate long-term effects and costs, there will be it will be great to get individual level data, or using causal inference techniques to address bias. Yeah. So we did not do that because again, we are lacking of data, or lacking of local evidence. Yeah. So we relied on summary statistics and expert. opinions. Yeah. And then for the model, just like other economic models, it will be encouraged to conduct model validation, such as internal validity, phase validity, which is that to invite other researchers that has not been involved in the study to separately validate whether this model, the structure, the data, assumptions, and results are all correct. Yeah. So we plan to do that by inviting a foreign researcher, Dr. Paul, to help us with that. And as I mentioned, that we need to consider structural uncertainty and parameterize it alongside with the clinical pathway, which we did for the FH care study. We considered test performance and uptake rate by proband and relatives. Yes. And incidental, we also consider incidental findings. We will discuss about incidental findings in discussion. And for the rest of the recommendation, it will be less of a priority, but we will strongly recommend you to involve the clinical expert into develop the inventory of impact, like listing the health and non-health effect of this intervention, and then also to here to break down the impact of this intervention onto societal and healthcare resource use, and to prioritize the disease indication for evaluation. And it will be great if we can also present results from budget impact analysis to further support decision making, although we did not do that in our pilot study yet, which will be a limitation. So to reflect what we have discussed upon, for population domain, it will be important to identify the target population, whether it's stratified or unstratified. And depending on different type of genetic tests, then you may want to involve different type of population. For the intervention pathway, the design should be involving clinical experts and consider the entire process from outreaching to conduct the test until the completion of treatment and the subsequent outcomes, and start with exploring the complexity of the clinical space and narrow it down to the most relevant and most feasible major pathways, using other pathways as potential comparators or your in your discussion. And for the comparator, follow the best practice to identify the common practice in the local setting, and potentially identify another very promising and best alternative in the market or to be launched to the market. And for costs and outcomes, consider societal perspective when measure these endpoints, and consider the full cost of the test and all the relevant direct medical costs and the productivity loss, if possible. And the cost may vary due to economies of scale and scope, which should be discussed at least. And the test negative patient may have additional costs, which should be taken into consideration. And for the outcomes, focus on the pick the best disease model that has been commonly used and focus on patient and disease specific outcomes. And for the time horizon, it will be encouraged to use a lifetime time horizon. And for tests that captures intergenerational effects, we may need to apply a specific discount rate for them. And always keep in mind to use generic models and best available data, best quality available data that can be representative to enhance adaptability and address equity and ethics issues in the design of the protocol that you want to really truly use the genetic tests and discuss about them or even quantify the impact. And for modeling, it will be the combination of the previous domains that we need to we need to follow the best practice to construct the model that is needed in accordance to the clinical pathway that you have designed, and also to integrate or parameterize decision uncertainty alongside, and to come up with an impact inventory and specify it into different domains by engaging experts, clinical experts into it. So once you are completing these checklists, then you can click on to generate a report. And for the report, you will be able to see how many recommendations that you have been used for your study. Like here, our FH case study is like between 60 to 80% compliance with this reference case. And for those that we did not adhere to the reference case, there will be some explanations, which will be helpful for you to write your study report. Yeah. And what time is it now? Sorry. We still have 5 minutes, so we're not going to talk about early intervention. Early economic evaluations guidance, but there are 30 recommendations for early economic evaluation. And when we present our case study, maybe you can have a look at them. Can I change back to or does Dr. Yo want to present the rest? Or?
No.
Okay, then I will use the rest 5 minutes to summarize. How can I do this? Okay, great. Okay, so as I said, the take-home message from using this reference case is to engage clinical experts and manufacturers in the definition of target population, clinical pathways, and model structure. Engage them early, even in the early developmental stages. And for the cost, we will be needing to try our best to identify all the direct medical, non-medical costs, and indirect costs associated with both the treatment, a test, and the treatment. And it will be important to integrate decision uncertainty into this analysis and to perform sensitivity analysis on them, including accuracy of the test, uptake of the test, compliance of the treatment, and even incidental findings. And the impacts of ethics and equity should be always bearing in mind when you are designing the clinical protocols and in your discussion when you report the results. So the advantages of using this PMRC as a supplement to the generic RC is to improve your decision making, to provide a relatively unbiased estimate, a more standardized estimate of cost effectiveness outcomes. It also improves the transparency and reproducibility of the findings. And by engaging stakeholders early, it will gain their trust and confidence of using the technology or designing better clinical pathways. And for the early economic evaluation part, it can improve the planning for research and development. And the unique feature is, as we have mentioned, that our PM is associated with complex decision space. We need to streamline the design of this clinical pathway and dissect it into different components and integrate decision uncertainty in the decision node. And also it's very difficult to obtain clinical evidence for PM. So we need to leverage real-world data and streamline the process of collecting cost and outcome data from the real world. And apply your own like a causal inference technique if possible. And the bottom line is, if nothing is available, then we can use surrogate outcome and expert elicitations with cautions. And this reference case also provide expert guidance to expedite the cost-effective implementation of a PM, which is to conduct the early stage economic evaluation in a progressive manner to support the informed development of PM technology. We'll be talking about that later. And there are some challenges and limitations of using this PMRC because first, PM technology is very complex and the cost can vary greatly in a short time. Like you have to discuss about that this cost effectiveness estimate, maybe it's just temporary and the cost may go down or go up, go down usually. And there are heterogeneity in patient outcomes that we cannot be addressing. We can only like heavily rely on patient expert knowledge. And the values and harms of additional knowledge that cannot be turned into economic terms easily should be acknowledged. And there hasn't been a good way to address incidental findings until the infrastructure of the healthcare system itself make relevant modifications. And for this PMRC, we haven't provided detailed guidance on the actual modeling practice, which is beyond the scope of RC anyway. And we emphasize on the expert opinion, but we need to develop a way to address the conflict of interest because the clinical expert can be the developer at the same time. So for the future of the PMRC, we will be updating the PMRC to integrate AI-based data-driven PM approaches. And also to address the omics techniques that face multiple diseases and specific guidance on further guidance on the how to extrapolate and harness real-world evidence. And we also plan to enrich the guidance on early economic evaluation part. So I think that marks the end of this.
Thank you, Dr. Vinsha Chen, for your detailed explanation on the reference case. I would like to take this moment to pause and ask from the audience if you have any questions. You can type in the chat. Our experts can answer them. And if not, we can proceed with our case study application that would be presented by you, Zhang Yu. She'll be presenting on application of PMRC in practice, a pilot case study from Thailand.
Any questions, any comment from participant? We believe on behalf of HITAP, we believe that this work is very important. The reference case will help us and all the Thai agency who are conducting health technology assessment, health economic evaluation in particular for the Thai government to make their work more transparent and systematic. And we are in a process. At the moment, Dr. Vincia and the team already developed the reference case, and we are in the process to consult with the authority in Thailand, including the National Health Security Office and the National List of Essential Medicine Subcommittee, whether and when we can put the reference case as a requirement as a checklist for HTA report to be considered by these two authorities. So if you also have any comment on this part, please prepare and feel free to share. You can share by raising your hand or you can type on the text box. I think we can process to the case study and then we will come back if you have any question. So thank you.
Thanks, Dr. Yot, and thanks, Paul. In the next 15 minutes, I will present the application of our PMRC in practice through the FH Care's case study, highlight on how this reference case guide the conduct and reporting of the economic evaluation on precision medicine. First, we acknowledge that the original model structure and the parameters were developed by a research team from Social Hook School of Public Health from Singapore FH clinical implementation pilot project. Then we adapt this model to reflect Thailand's specific clinical practice. Next page, please. As you can see from the overall flow chart of the study design, we try to develop economic models for FH care in Thai settings. During this modeling process, we recorded challenges and their relation with the PMRC recommendations. Following this, in order to verify whether PMRC sufficiently cover PM specific challenges coming across in this average care case study, our research team checked and discussed whether we face challenges beyond the coverage of the PMRC. Then we label each PMRC recommendation as applied if the study managed to appropriately consider the recommendation. Not included if the study not managed to consider the recommendation. Not applicable if a specific recommendation was not relevant to the case study. This step helps us to check whether and how the case study managed to address the recommendations. Finally, we reflect on PMRC's practical applicable with regards to the content and the clarity, and discuss whether the PMRC need additional amendment. Next page, please. Overall, for the conventional EE, more than 60% of the 39 recommendations were applied. Similarly, for the early EE, 79% were fully incorporated. Although some items were not applicable or not included in this analysis, these items of reference case remain valuable and eligible for application in other PM economic evaluation. It was not felt there were any inadequate or inoperable items in this PMRC. The 9 domain provide a comprehensive coverage of the challenges coming across in this FH care case study. We didn't identify new challenges that were not in the PMRC and were unique to the field of PM. Next, I will present the applicable of each domain of the PMRC in this case study, separately for conventional EE and early EE. Next page, please. As for the conventional EE, this analysis focuses on a diagnostic test for the early detection of the genetic FH. In line with our PMRC recommendation, we firstly form an expert panel consisting of health economists and clinical experts from Singapore and Thailand. Our working group critically appraised the previous reference study regarding its relevance and feasibility, then adapted it for the Thailand clinical practice. As can be seen from the figure, clinical experts revise replacing the next generation sequencing JNS in Singapore model with WES, whole exome sequencing, and added MLPA as the confirmatory test to reflect Thai local settings. Next page. For comparator arm, all possible comparator options were discussed with clinical expert group. During this process, Thailand experts comment that the current practice in Thailand is limited FH screening, predominantly through random screening, with the DLCN and cascade screening not commonly practiced in routine clinical settings. Thus, this current standard of care was considered as a common comparator in our economic analysis. As can be seen in the figure, it was defined as random lipid testing alone, no DLCN, no genetic testing, and no cascade screening. Next page. We follow Thailand local HTA guideline as recommended by PMRC to adopt societal perspective, thereby incorporating both indirect costs such as the cost of productivity loss and indirect and direct non-medical cost, including informal care cost and travel expenses for the patient and family. Following PMRC's recommendation, we identified all relevant direct medical costs, as can be seen in the figure below, including one-time screening test, pre-CVD lipid control cost, and incident CVD disease cost. The one-time cost of the virus screening test includes first the lipid testing, second the DLCN, and third the genetic testing. The genetic testing costs include patient recruitment, sample collection, and testing in interpreting and communication of test results. A checklist of costs identified from the literature and the reference case model was sent to 8 health economist experts in Thailand to prioritize the most influential cost items. Thus, the expert opinion were highly adopted to determine the relevant and influential cost items to be measured. However, the impact of potential variation of PM unit cost and cost differentiation between different turnaround time for test results were not included in this model. This is part due to the limited data, and we will consider these issues in the discussion part. Next, please. For the outcome measurement and evidence generation, following the PMRC recommendation, this study adhered to the hierarchy of evidence to ensure data robustness. The process of data collection is shown in the bottom figure. We first based the input parameters on tertiary public hospitals, systematic literature search, and Thailand local database. Please note that meta-analysis were performed for parameters with multiple data points gathered from published studies. If no data were available, as the first step, we conducted individual interviews with experts to distinguish between transferable and non-transferable parameters. Following this step, we rely on our previously published study to get input parameters for transferable ones and conducted expert elicitation for non-transferable ones. As for the harmful outcome, the disutility from statin treatment was incorporated. However, other potential adverse effects due to false positive were not modeled, such as psychological impacts post-genetic testing and risk of misdiagnosis and overtreatment. In addition, the impact on social value were not incorporated because we don't think FH will affect the social value. Next, please. A lifetime horizon were considered for both index persons and their relatives to model all relevant cost and health benefits. Our analysis adhered to 10 methodological guidelines for modeling and decided the discount rate for cost and quality at both 3%. This study, however, does not capture the intergenerational effects. This limitation may be addressed in the future research. For ethics and equity, we get the input from Thailand clinical experts and ensure the principle of non-discrimination and equity of opportunity are applied in the analysis and policy recommendations. Regarding equity, all subjects from FH should be equally screened for genetic testing, regardless of race, sex, or health coverage plan. Regarding ethical issues, all subjects should receive genetic counseling before and after the genetic analysis. Next, to enhance the generalization of our findings, this study applied the generic disease progression model from pre-CVD to primary CVD event and finally to death to inform the Markov model. Additionally, national data for Thailand were obtained from local real-world sources, such as FH registry, tertiary public hospitals, and Thailand standard cost list for HTA. However, multiple sensitivity analysis, including the one-way sensitivity analysis and probabilistic analysis, were used. For the determination of model structure, we discuss with clinical experts and health economists. Begin with the pre-specified type-specific intervention and comparator pathway. We added several decision uncertainty parameters to the model, including the test accuracy and uptake rate by both proband and the relatives. The figure below shows how the uptake rate and test accuracy could be incorporated into our model, taking the proband screening as an example. Next, please. Okay, now I finished the conventional E part. I will quickly go through the early economic part. The leading clinicians in Thailand are locally developing the new technology LRS for the diagnosis of FH. It was still at the clinical development stage, so we selected it for the early economic evaluation based on the nomination from expert team. We then applied expert elicitation for formative evaluation to inform technology. As the technology has passed the early stage, the technology developers have already proposed its positioning in the clinical pathway, taking into account the healthcare system readiness and the public perceptions. As can be seen in the figure below, in comparison with WES in the conventional EE, the pathway of screening using this new technology is quite similar to the conventional one, except for the presence of the confirmatory test. Every negative test result of WES is followed by a confirmatory MLPA test, whereas no further confirmatory test is needed in the case of negative LIS test. LIS protocol similarly encompasses cascade screening for first-degree and second-degree relatives of probons with positive genetic test. Next, please. The comparator chosen was the standard of care, which is the randomly paid testing alone, as well as the best competitor conventional genetic testing WES. We compare the new technology LRS against these two comparator together using three criteria: the minimally acceptable target, the acceptable target, and the ideal target. Next, please. We delve into the resource utilization for the whole process of implementing this new technology LRS, including laboratory and manpower requirements. This helped to update the checklist of to be measured cost and calculate the package cost of LRS. The table below shows the included cost per components per sample based on the logics for the LRS. We try best to gather the most valuable information based on the cost and performance of LIS using two possible approaches. The first is to obtain potential values from pilot studies conducted by the medical innovators. In the absence of data, the second one adheres to the standard approach to elicit expert opinions. Next, please. For the time price freeze frame, we also employ the ideal lifetime horizon to consider the long-time data. For ethics and equity, the main concern is regarding the medical insurance. Thailand doesn't yet have the genetic information non-discriminative act in place, which means that insurance companies, if they have access to patients' genetic test results, may discriminate against patients taking out insurance plans or refuse insurance claims. Whether insurance companies will have access to the test result remains an issue that needs to be carefully addressed. To ensure the adaptability of our results as recommended by PMRC, this study involved regular stakeholder consultation with the technology developers. Next, please. For the modeling and the analysis, we explored what product profiles is needed for LIS to be cost-effective and assess multiple levels of uncertainty through a stepwise approach. Firstly, we perform threshold analysis to explore at which value of one parameter for LIS to be cost-effective. And then two-way analysis were conducted to explore to consider two levels of uncertainty, including the test accuracy and test cost at the same time. For this purpose, as shown in the left figure, please click. Yes, in the left figure, we examine the acceptable maximum cost package of LIS at varying at varying performance. Lastly, as shown in the right figure, we use scenario analysis to explore the cost-effective probability of LIS in the market and a different scenario of LIS uptake rate. For modeling to determine the target product profiles, we only consider the headroom method. The statistical method was not incorporated because our model is too complex. Yes, that's.
Thank you very much, Yuan, for presentation. Actually, if you the participant can see that the case study contain of both traditional HTA and then the early HTA, and you can see the difference between traditional HTA and early HTA. Well, for traditional HTAs, as we are more familiar, we trying to get an outcome in terms of incremental cost effectiveness ratio. So we get ICER, and when we compare the ICER with the thresholds, we can come up with a conclusion whether the intervention is good value for money or not. And for the early HTA, the ICER is not a big issue. It's not the main point that we want to see, but we want to see what are the characteristics or target product profile or preferred characteristic of the product that can make that product become good value for money. So the outcome, the conclusions, and the main primary result will be different, and that's why we need to have a separated reference case for both type of evaluation, ensuring that both studies are transparent, systematic, and point out to the main result that we want from each type of evaluation. I think that is give a lot of good idea and including the case study. So now we come to the last part of the webinar. We have allowed 8 minutes. Are there any participants who want to ask questions to both? I think three, Dimple, Professor Winjia, and then you, or you want to even discuss on a general thing, for example, regarding the use of this reference case when you need to submit evidence for reimbursement. If not me, while we are waiting, can I ask Dr. Winjia now maybe that if the participant want to know more about how you come up with this reference case, what is the study behind that can give you input for development of the reference case, and are there any detail that they can read regarding on the reference case? Can you point out where they find that information?
Yes, thanks, Dr. Yao. So it's a long journey for us to develop this reference case. We first conducted a systematic review on all the economic evaluations of precision medicine, including 275 CA papers in the past 10 years. And we systematically assessed their methods, the approaches that they use to conduct early and conventional economic evaluation. Then we drafted another paper that we actually drafted another paper that summarized the methodological challenges of conducting economic evaluation on precision medicine. And in those methodology papers and discussions, we actually have already identified solutions from the original paper. And we then drafted the better version of the reference case, and we conducted a workshop last year in Khao Yai, Thailand, including 17 experts from the leading pilot study teams from Singapore and Thailand to give us the pilot test, to refine our tool based on based on a word cafe manner for each recommendation that we made. And so these three activities we have drafted manuscript for each of them. The systematic review, the methodology review, and the making of the reference case workshop, including the beta version of the reference case. So yes, in response to Dr. Yo's question, so you can find information about our how we come up with this reference case through these 3 publications. One is just submitted. Yeah, and we also have another publication. Another under review manuscript on the PMRC itself, and we will be submitting a manuscript on the case study, the pilot test study on the FHA care. So we will be having 5 paper together to help you understand the journey of making the reference case and how it come from and where it will go.
Good. Okay, we already share the reference of 2 published study that Professor Winjia mentioned on the chat. If you like, you can click and you can download. I think both of them are open access, so it's publicly is available. We have a few questions now, Professor Winjia. First is that the question is, how is this PMRC, the reference case for precision medicine, different from generic reference case? I think this is very good.
Just as we said, how to design the clinical decision space and come up with the major intervention pathways, comparators, and how to collect evidence, extrapolate evidence for cost and effectiveness. So we make very specific recommendation about designing the clinical pathway and to identify the major intervention and comparator pathways, and also to collect evidence and costs, the components to be collected. And also we recommended like a disease specific outcomes, patient specific outcomes, rather than like outcomes tied to a treatment, because this is a test in a sense. So it should be used in as a supplement to the generic reference case. It addressed some of the unique challenges due to the complexity in clinical pathways and lack of clinical evidence. And also it provides unique guidance on the early economic evaluation part, so as to better help the developers to engage experts, gain their confidence in use, and also expedite the process of the new PN technology to be implemented in the market.
If this mean that if we develop or we adopt the PMRC, the generic reference case is only subset. So it means, do we need to also consider another guidelines or checklist, or this can be used in concurrent? I mean, we use both of them at the same time. Which one
Yes.
you recommend?
Yeah, I think we should be using them both at the same time. So for the basic structure of the model, we did not make very specific recommendation, but I believe most of the reference case will not make very specific recommendation as well. So in general, you should adhere to the generic guideline to meet the basic requirement of cost effectiveness analysis. And on top of it, there are specific issues that when you read our PMRC, you'll be able to address for the unique healthcare paradigm of PM.
Okay, I think we have only time for last questions. The question is, how can participants use the PMRC in their research? Can they, whether they need to use at the beginning when they design study, or they just use like a sheer checklist that they are reporting at the end?
I would strongly recommend researchers to use the PMRC at the start of their research design, and even better when the technology is still under development. Yeah.
Good. Thank you very much. So thank you for all participants. I think we come up to the time, so I come back to Dimple.
Thank you everyone for taking time to join this webinar. If there are any other questions that you want to ask us, you can feel free to reach out to us at our website. You can reach out to us, and Thank you once again. The recording of this webinar would be made available online, so you can go and watch on our YouTube channels.